So it's my proud privilege to introduce to you Nicolaas Budhiparama from Indonesia. He's been the past president of APKS, Asia and APAS, and he's the only Indonesian orthopedic surgeon who also practices in Europe, Netherlands. So, Nico, we are proud to have you here, and over to you to give your keynote on the era of globalization, what we need to know about regional bacterial strain.
Good morning. First, again, I would like to thank Professor Parag Sancheti and Dr. Sachin for inviting me here. Today, I would like to share with you about the era of globalization, what we need to know about the regional bacterial strain. This is my disclosure, my collaborators, Javed Parvisi, Torsten Gerke, and Maria Wouthuizen. So if you come to a conference or a course, usually the faculty shows you how to rule out infections and then how to treat it 1 or 2 stages and with spacer you might need it, and how to reconstruct it. During the operation, sometime you might need a extensional exposure, tibial tuberosity, and for the exposure, or you see that these patients after 4 revisions, and how to reconstruct it with a metaphyseal or cone. So the principle is of the treatment of the PGI, you have to know the diagnosis and the good therapy treatments and try to get the germ. But don't forget, antibiotic don't heal the infections, and identify the risk factors from the patient's perspective and from the difficult to treat microorganism. But what I would like to share with you today is a global perspective on PGI. Remember, bacterial and fungal specific to certain regions can nowadays be found in another regions, and local patterns of the bacterial strains and spread of resistant bacteria throughout the different regions. If you look here, enriched germs of the various places of the human body in diverse populations around the world. For example, the germs in the continental United States, in Europe, or in Asia Pacific is different. And the microbiome, you can see here the kind of cells in the human body of humans, bacterial and fungal. It's trillions of human cells and 3 trillions of microbial cells. So this brings us to the big questions. How does infections persist? And why do pathogens keep emerging? And are we truly confronted with a new pathogenic species and strains? There are 3 main aspects need to be discussed. Discovery of new pathogens, same old pathogens but new exposure, and same old pathogens with different properties. And this all made possible nowadays by globalization. We know that the risk of inter-country transmissions of the microorganisms can be due to the burgeoning industry of the medical tourism, leisure tourism, and changing patterns of the human migrations. This publication shows that Asia is the most common origin of travelers with resistant bacteria. It's covering about 36% of the total isolates. So international travel is a vehicle for the transmissions of the antimicrobial resistance globally. I would like to show you that the different regions with a different microorganism. For example, Enterobacter cloacae, which is quite common in France, found in the hospital ward. If these patients now move to the United States and develop a PGI, the first thing that the doctor gives there is a first-generation cephalosporin. Well, we know that the resistance. Other thing is like Candida parapsilosis is isolated mostly in Southeast Asia. So if these patients move now to live in Europe, there's delayed diagnosis due to difficulty in identifying the organism. Look at from the 2 big centers, the Rodman Institute shows here, there's more Staphylococcus aureus found, while in Europe it's more Coagulus negative staphylococcal. So what I'm saying like this, it's the same meat, but it's different in different 3 continents, 3 different tastes, and 3 different preparations. So the trend of PGI causing organisms remain unchanged over the years. But the developments of antibiotic promises treatments. But why there is still an increasing strength in PGI? The international crisis, the slow-growing organisms previously considered as a contaminant, such as Staphylococcus aureus, are now being recognized as the serious pathogens and causing serious PGI difficult to treat. And there's no new antibiotics are no longer being discovered, and resistance mechanisms are occurring in almost all clinical isolates of the bacteria. So I would like to show you the controversy of the diagnosis of the PGI. We wrote in the definitions of periprosthetic joint infections in in 2018 international consensus criteria, divided in the major criteria and minor criteria. So what is the controversy on the same year in 2018 that between the ICM, there's another group, the European Bone Joint Infection Society, proposed another guidelines. If you look at the 2018 definition of PGI, the validation result of this 2018 definition as compared to the original MSIS or ICM in 2013, if you look at the false negative, that was about 20.7%, now it's becoming 2.3%. While the European Infection Society say they lowered down the cutoff because low-grade infections can be missed and overdiagnosed in a risk with a false positive test. So they proposed a 3-level approach. How about the new advancement in diagnosis of PGI? We know the classic one, the CRP and ESR, but there's some limitation in monitoring response to treatments diagnostic in setting of low virulence organism. Nowadays, we can look at the interleukin-6 level, were significantly elevated in PGI. So a summary of this new development in PGI diagnostic strategy in the serum, you can look at the interleukin-6 or synovial fluid with alpha-devancins or synovial CRP, while the periprosthetic, if you have the tissue and the implant, you can look at the PCR, NGS, or sonications. So nowadays, when time matters in the hospital, automated systems can detect an early biomarkers for the potential life-threatening conditions. We know that the genomic and infectious diagnosis, that a next-generation sequencing has a potential to dramatically revolutionize the clinical microbiology laboratory by replacing current time-consuming and a labor-intensive technique with a single, all-inclusive diagnostics test. So the advantage of the NGS are it's a promising and accurate pathogen identification and improved time to specifications, and NGS isolated organisms about 89%. So it's a novel method to monitor the infection's clearance. And this paper from Tarabici shows that pathogen causing a PGI in both culture negative or culture positive synovial fluid could be identified by the next generation sequencing. But the controversy is this from Kildo shows that NGS did not provide superior sensitivity or specificity. And even the PCR standalone test is only about 18.4% sensitivity. So the issue that remains is the PGI and other infections may be polymicrobial, a signal that NGS isolated organism may result in later failure. How about the treatment? Some controversy, 1 or 2 stage or the DEA. You know, the significant challenge to both the surgeons and patients, but the challenge for the surgeons are removing a well-fixed prosthesis, difficult reconstruction. The ideal is implant retention without infections. So, for example, a patient just was operated about 3 weeks ago and developed a PGI. What is your choice? 1 stage, 2 stage, or you do it there? So we published this in the Journal of Arthroplasty, and besides that, I wrote a chapter on my book on infections in knee replacements. The decisions to retain the implants depends on not immunocompromised PGI caused by low virulent organism and biofilm containment. So It's crucial to eradicate biofilm within a short time frame before it attaches to the implant. 1 or 2 states revision that if you look at mostly of the publication in Europe, it shows here that the single states is superior. So you see that here, no reinfections in 28 treated with 1 state, while 5 reinfections in 74 treated with 2 states. And they said here, 1 state revision is similar outcome in reinfection, re-revision, and readmission. Even in culture negative may not be a contraindication to 1 state revisions. And we know that the negative culture is paradigm shift now, the culture-based to molecular-based methods. But as you know, that in United States, they don't believe on the 1 state, and this even one of the European publisher shows here, and researcher shows here that the 1 state is similar infections, but should be interpreted with caution since selection bias may have played a significant role. So they claim that 2-state revision is still the gold standard. And Hutler shows that studies focusing on complications, success rate of 2-state revision is overestimated. 2-state revision is associated with high rate of wear during the interstate period, high complications rate and recurrence of infections, and high rate of mortality. So in the United States now, since a couple of years, becoming a more populous 1.5 states exchange instead of 2 states. Well, the controversy on antibiotic prophylaxis, the type, dosage, timing, and durations. In the United States, we know that there are disagreement in recommendations for antibiotic timing. Because 2017, the CDC releases guidelines that single dose of preoperative prophylactic antibiotic is enough. But HKS does not agree with these recommendations, and they recommend postoperative antibiotic be continued for 24 hours. Well, later, Tom Faring and Timothy Tan shows a single dose of preoperative is as effective as 24 hours. But we have to be careful. If you look at the latest publication, shows that in high-risk patients receiving only perioperative antibiotic were more likely to develop PGI. So they give for about 7 days. And besides that, antibiotic usage, vancomycin still used in the United States, while in Europe is restricted use of vancomycin. And in Western countries, 2nd generation cephalosporin prophylactic antibiotic, while in Asia, mostly they use a 3rd generation cephalosporin. So the question now, can the AAOS and HKS guideline be applied throughout the entire world? This publication from India shows that developing and developing countries do not share the same weather, theater conditions, pathogens, nor socio-economic background, so cannot share the same antibiotic timing and duration as the developed countries. Even in Asia countries being hot and humid, it's a conducive environment for brown gram-positive, gram-negative bacterial. How about multi-drug resistance, which is increasing over the past 10 years? And we know that then why is antimicrobial resistance is a global concern? Because antibiotics are becoming increasingly ineffective. The cost of AMR is increasing and limited rate of new antimicrobial discovery. Again, if you look at the MRSA publication on the same year, the American state is more in Europe, where the European state is more in the United States. So it's all controversy. At last, this from J. Parvizi, he said that despite the increasing clinical focus, research advances, and growing in the literature relating to the PGI, they are unable to detect any substantial improvement in the treatment success rate of PGI at their institutions over 17 years examined. So novel treatments and techniques are certainly needed, as current and prior strategies remain far from the optimal. So my take-home message are, cannot slow down the globalization. Be aware when treating patients from a different continent. Thank you very much for your attention.